Welcome and thank you everyone for joining at this quarter's edition of the ACS Journal Club. My name is Eric Wagner. I'm lucky to be joined as usual with Chris Clifto, and we have three incredible experts on this topic of the primary rotator cuff repair. So Jason Hughes from University of Washington, Rachel Frank from Colorado, and Joe Bood from Rothman. So three of the sort of biggest thought leaders and kind of leaders in this arena. Really excited to join with them for the next hour and kind of learn. And we appreciate you all for joining. Please make sure you tune in as you're engaging, ask questions. You can use a Q&A link or the chat, and both Chris and I will be monitoring that. Chris, anything you want to say before we go to the sponsors?
No. Yeah, so please put any questions you have in the chat. Pete McDonald is going to be joining us as well as a guest panelist. And keep it lively, and we'll make sure to get all your questions answered.
Perfect. So, and thank you, Smith and Nephew, for the sponsorship. This is a quick video that they're going to share before we start the articles.
When precision is demanded, when every case is different, when time matters most, robotics should work with surgical skill, supporting judgment, fitting naturally into the workflow of shoulder surgery, amplifying what the surgeon already does best. Personalization across reverse and anatomic, designed for the complete procedure. Confidence where it counts. The freedom of handheld robotics. Cori XT. Skill amplified.
Fantastic. Awesome. Well, let's get started. So we're going to start with the subscapularis study and then kind of go from there. So the first study is on the comparison of upper one-third subscapularis tendon healing. This is a basic science translational study with rabbits. So what they did is they looked at three different suture configurations: single road, modified Mason Allen, and an H-loop knotless technique. So basically two knotless techniques and then one tied technique. Looking at time points of 0, 4, 8, and 12 weeks, both biomechanical and histologic testing. So ultimately, when you looked at just the 8-week results, they found that both histologically and biomechanically, it seemed like the H-loop and the MMA had better signs of bone tendon interface maturation, biomechanical loads. When you looked at inflammatory profiles like M1, M2, and some other markers, that it seemed like they had less inflammation and better type 1 collagen deposition, and then ultimately better bone tendon integration from a biomechanics standpoint. And it seemed like this kind of trended both at 4 and 8 weeks, but was most prevalent at 12 weeks. So it's kind of an interesting study. It's kind of building upon some prior studies that looked at biomechanics, assessing single versus double row and knotless versus not repairs or tied repairs. And it sort of adds maybe some histologic and translational aspects of this. So I think this is what you can take from rabbit studies. Obviously they heal a bit different, but it's nonetheless kind of interesting and nice contribution. So I guess starting out with just subscapularis in general. So Rachel, when you are approaching like an upper third subscapularis repair, do you want to share some technical tips of how you like to repair it? Kind of what is your preferred, usual suture technique, and kind of how someone can approach these as part of their repair construct?
Sure. Well, first, thanks for having me as part of this esteemed group. Definitely an honor to be up here with all these superstars, including you. And so, when it comes to subscap, first you got to recognize it and then fix it. I'm pretty aggressive with fixing those upper border tears. I'm a simple surgeon, so I'm more of a single row, simple stitch configuration, knotless or double loaded knotless configuration using a suture anchor, and often incorporating a biceps tenodesis into that anchor to try to minimize implant costs and maximize footprint coverage. And this study gives me some pause. Maybe I'm doing the wrong thing in terms of what they found biomechanically. I will go to a double row when it's a little bit more than that upper border, a little bit, more of a retracted tear, more of a chronic tear, or I have to do a little bit more work. I think when I look at this study, there certainly are some strengths. It's a well done study. There are some limitations. That's not a suture anchor technique. So I think we have to be careful extrapolating what was done with bone tunnels for all three techniques compared to the suture anchors that I'm assuming most of us, if not all of us, on the call and with the participants use. So you can't really do that in New Zealand white rabbits, but it's important to understand that anchors and bone tunnels are not the same. And so I think this study gives me some interesting data to look at. Maybe I need to do a more biomechanically robust construct. But yeah, I'm more of a simple stitch or knotless configuration, and I've gone to using a knotless all suture anchor with two knotless repair sutures. So it's not a double row, but it's two sutures for the price of one anchor for most of my patients.
Amazing. That's awesome. So Joe, do you want to share some of your tips on subscap? So with regards to both the entry anchor configuration, the difference between your repair techniques, if it's one third versus maybe a complete subscap tear, how are you getting good visualization, et cetera, with maybe some of the fellows and young attendings managing this arthroscopically?
Who was that directed
Oh,
to? I'm
sorry,
sorry.
Joe.
Oh, so in my career, I was just looking here. I was Jason's attending when he was a resident. I know much younger, and Rachel's much younger than I am. Chris was my mentee for the ASCS mentor. So definitely the elder statesman, I guess. So I've done everything. I've done the I don't see a subscap tear to I'm not really sure I have to fix subscap tears to I should be fixing all subscap problems to um, there's nothing wrong with doing them all arthroscopic to the big ones are going to do open, the smaller ones are going to do arthroscopic. I'm going to do single row, double row, luggage tag, knotted, not knotted, soft body, hard body anchors. End of the day, the subscap's very important. I think that, as one of my residents said about 10 years ago, he goes, I was just on the, no offense, Rachel, the sports service, and I didn't see a single subscap repair. And I said, well, I guess they don't either have them or they don't see them. So, I think they're more common than we think. I think sometimes when we're starting our career, they seem annoying because if we're a beach chair operator, it throws our orientation off. And if we're a lateral decubitus person, it's probably a little bit more straightforward to do it, but we're less likely to be lateral decubitus if we're shoulder elbow. So I think that, I've, for large tears that are retracted, I feel very comfortable doing it in an open technique. I know that a lot of people have great videos dissecting out the nerves arthroscopically and showing us the vessels pulsating. I know there's several salvage techniques that have been discussed, including latissimus, including now transscapular lower trap, which is being popularized by Thibault Lafosse and Bassem El Hassan. I think those all have some promise. But again, based on what Rachel said, it's an animal study. It makes you want to think about your construct a little bit more. At the end of the day, learning from your peers is important. Learning from your patients and your level 5 experience over 25 years is important as well.
Yeah, fantastic. I love that bird's eye view. That's very comprehensive. Jason, for you, just going back to maybe the knotless versus knotted, I'm tied. How are you deciding? Do you have one you prefer for most subscap or maybe even for the smaller posterior superior tears?
Yeah, I used to do knotless for upper subscap, but I found I've switched to doing knotted just because I have better control and I can pull on the sutures and really get a better repair, I feel. So I do a knotted anchor for arthroscopic subscap. So just to emphasize Joe's point, I think I missed a lot of these in my early years. If you don't flex, internally rotate, and push the humerus back, you can miss these very easily. And so I think I missed a lot of them in my early years. But I do them intra-articular, upper third. I used to do them with a 70-degree scope, but I just do it with a 30-degree now. I use a knotted anchor. I'm like Rachel. I'm simple. I just use simple stitches. I don't do anything fancy. I pass as many sutures as I can through the upper subscap and do it arthroscopically for upper border tears. And then I'm like Joe, I go open. If there's a big retracted tear, I like to palpate the axillary nerve and vessels, and I like to know where it is just so I don't run into any complication. So I'm going open, doing a double row for the bigger tears. Um, yeah, so I pretty much do all knotted suture anchors for all my repairs.
That's awesome. It kind of leads to the next article we have, but augmentation of posterior superior tears has kind of taken off. That's a really popular topic right now, obviously, almost everywhere you go, and many of us have incorporated it. Have you incorporated augmentation into your into subscapular tears, maybe like a big retracted complete tear? If so, what type of augmentation?
So I have not. I've been very interested in it, and one of our fellows, Jay Check, has did this huge review on biologic augmentation to look at the results, and the overriding theme here that you'll see in everything is that the re-tear rates definitely go down, but the patient-reported outcomes are pretty similar whether or not you use augmentation or not. And so it's not very clear that the patients benefit from it, but the re-tear rates definitely are lower. The question is, if you are augmenting something, you're putting a patch on it. My question is like, you know, if you look at the Sugaya classification, all these studies look at Sugaya 4 and 5 as being re-tears, but how do you what do you think of Sugaya 3 with an augment? Like what is the translation there? And so it always kind of makes me wonder like if you augment something but you still have you know you might have failure in continuity essentially where you have your augment or your patch there and it's very thin. What does that mean in terms of how that's doing? What is it exactly doing for the patient? So interested in the panel's thought on that.
Yeah, no, that's great. Rachel, Joe, do you wanna jump on that?
I would say I've not augmented my subscaps. Even if I'm opening to do a massive or retracted subscap, it's probably a good idea because I'm pretty aggressive with augmenting my posterior superior cuffs. So you would think, why not augment your anterior cuffs? I think arthroscopically, it's a bit more technically challenging to do it from the front, just from a visualization perspective and working space perspective. I think intuitively it makes sense. I mean, if you follow the same principles as to why you would augment a posterior superior cuff, you might want to consider augmenting an anterior cuff. For me, those subscap tears, I'm again very simplified. It tends to fall into kind of arthroscopic upper border or upper 50%, not retracted. I can really do this quite easily to either opening and I'm getting that tendon right back down to the bone. And even if it's very thin, I just tend to in those cases repair with a double row because it's a big retracted tear. But probably should be giving more consideration to augmenting the front.
So I augment the front um, with either dermal allograft or something that's structural and biological um, on fully retracted tears. Um, because I find that especially that lower third is so wispy as far as not having much tendon. I like to have I create like a taco around it so I can really pull it over. Sure, there's probably a tear in continuity or a tenodesis effect, but at the age that I'm doing it is probably a beneficial thing. The other ultimate to augment is the reverse arthroplasty. Just kidding. But yes, I do augment the front, probably in the bigger tears 30% of the time.
That's awesome, Joe. Joe, we're about to talk about SCRs a little bit later, but is there any roles for anterior capsular reconstruction, at least in your mind? You talked about some of the innovations and kind of bigger subscap tears. Do you think, tying a dermal allograft to the glenoid and then bring it over to the lesser tuberosity and then repairing what you can over top has a role? Is that something that's ever going to catch on, or is that just doesn't make sense just because kind of like SCRs kind of fade out?
I think it helps with stabilizing the head from translating anteriorly, which I think is an important aspect of being able to initiate forward elevation. The question is, you know, what kind of bone are you dealing with and how quickly will it tear out before it fails? So I personally don't have experience doing that, but I think intuitively it does make some sense in trying to preserve the joint and stability of the joint, especially if part of the problem is the instability that they're having, or even potentially the anterior escape potentially. But um, I have no experience with it clinically.
Chris, you want to go into the patch one?
Yeah, it's and Joe, my upper border one anchor repairs usually end in reverses, so I know what you're talking about. All right, so next one is patch augmentation for large to massive rotator cuff tears, heal well in anterior cable disruption. And the purpose of the study was to evaluate whether patch augmentation is still effective in the presence of anterior cable disruption, which has not been studied prior to the study, but as we know, has shown good results in massive cuff tears. This was a retrospective review of patients who underwent arthroscopic repair with augmentation for repairable large massive rotator cuff tears, and they defined as these poor repairable cuffs as anyone who had a Pate classification of greater than 2, compromised tendon quality, fragility with repair, severe fatty infiltration, till grade 2 or 3, or reduced acromial-humeral interval. So these are pretty significant tears. The patients were divided into two groups according to the integrity of the anterior rotator cuff cable, including intact cable group and anterior cable group that was disrupted. Patients had 24 months follow-up, and all patients had PROs and structural evaluations like AHI and tendon thickness and re-tear rates. They had 78 patients that were in the study. Mean age was 64. Both groups demonstrated significant postoperative improvements in PROs with no significant difference between groups. And both reached MCID. Range of motion was not difference between the two. MRI demonstrated a significant decrease in combined thickness between the two groups, 29%. Overall re-tear rate was 6.1% in the intact cable group and 10.3 with the anterior cable disrupted group. So this study concluded that there were similar good results with and without cable disruption. So maybe Joe, I have a question for you. These are some of the more challenging just rotator cuff tears to treat, period. Do you have any tips for everyone watching how you actually repair anterior cable disrupted rotator cuffs?
Um, well, I mean, first of all, I think I do all the steps that I do with most tears. I do first delineate understanding the tear pattern, making sure I mobilize it, making sure I get it, understand the bone quality and how much I can stimulate the bone without violating the purchase of whatever you're using, whether a hard body or soft body anchor. I've become much more of a utilizer of the biceps. I know Peter McDonald is on right now, and I think that is a non-disruptor of my workflow. It's cost efficient. It's right there, and so I think that to me is helpful. Don't use a lot of dermal allograft, but definitely this seems to be very supportive of considering using that if cost is no issue. And so I think providing biomechanical strength in that area is very important, but also some biology, right? Not a ton of biology in this situation, but some biology. So that's kind of the way I approach it. I also again if I can I do believe increasing the acromial interval with something. Again, not espousing a product, but something does help offload that repair while it's trying to heal.
Yeah, fantastic. No, that's awesome. So Rachel, when you are augmenting, do you want to talk about one? How are you doing it? Are you you mentioned you do a fair amount in the posterior repair. Are you incorporating it into the medial row? Are you bridging or kind of going across or bridging the gap? Are you just putting it just to kind of prevent a type 2 tear? Like, what's your preferred augmentation technique, and does it vary depending on the tear configuration?
It's a great question. I wish I had a simple answer, and yeah, I wish I could say I do the same thing every time, but I do try to customize it to the patient. I think number one, getting the cuff tissue repaired if it's repairable is critical. So that's number one, and trying to get that cable reconstructed or repaired if you can, I think is the most important thing you can do, regardless of augmentation. I try to look at the pre-surgical risk factors, the things that I can't control, such as the patient's age, the tear size, retraction, fatty infiltration, their goals, and kind of those Rohe factors. I don't get a bone mineral density on everyone, but I extrapolate their bone quality on their X-rays, and then if I have a vitamin D level, I try to use that. And if they seem to score above 4, to me, in a primary rotator cuff case, that's a good indication for augmentation based on some of that data out of Korea. I think there's some controversy with that because, again, we don't evaluate all the factors in the same way that those original authors intended. And again, I think a lot of companies are pushing augmentation for a variety of different reasons. And if you own your surgery center, that is a consideration, unless it can be built as an implant. And then if you get reimbursed for implants, that could be cost effective for your center. It just depends on what your setup is. So that's a long-winded way of saying there's a lot of factors that go into when I decide to augment. When I do decide to augment, I'm typically using a human dermal allograft. And if I'm augmenting on top of a repairable cuff, I like that augment to be about 2 millimeters in thickness, if I can. I do try to incorporate it into the repair and make sure that that bone tendon interface is covered, as well as some of that more medial tendon. I try not to really get it into the muscle. I don't know that that's doing much if it's in the muscle. I think that, as Joe mentioned, increasing that acromial interval is really important. We've learned that, and there's a variety of different tools and techniques for that. And then finally, I've started doing, and I see Peter on as well, but for some of these more difficult to repair tears, kind of incorporating what we're classifying as a biologic footprint reconstruction. We're putting human dermal allograft on the tuberosity to thicken it up, typically a 3 to 5 millimeter patch in that case, and then repairing the cuff over the top and trying to get some cuff down to the bone as well by lateralizing the graft slightly. So doing those in kind of the bigger tears, tears that are under more tension, tears that I might otherwise want to medialize the footprint a little bit to decrease the tension. So doing a lot of different things with augmentation. I think for me, the trickiest part is I don't really know what works in my patients. I don't have 10-year follow-up on these patients, throughout my career. So it's hard to say that I feel better at the time of surgery because I did it. I just don't know if it's helping. But I like leaving the OR feeling better. I will say with this study, what was really interesting, and I'm kind of a nitpicky kind of person, the authors hypothesized that adding the allograft with anterior cable deficiency would result in outcomes comparable to those observed in tears with an intact cable. I thought that was super interesting because just by definition, if you don't have an intact cable, you're probably going to do worse. The data is really clear on that. So it almost seems like the hypothesis was kind of driven after the fact. I'm curious as to if the rest of the guys on the call think that. That was just very unusual to me. And to me, the whole point of doing the study is to answer a clinical question. And if you think they're comparable, I just, to me, that'd be an interesting conclusion to come to pre-study. Those were just some of my thoughts, kind of looking at this particular study. That being said, I was pleased with the outcomes. Maybe I don't need to spend so much time on the cable.
Fascinating. Jason, what do you think?
These
Both
are,
about, yeah.
yeah, these are pretty impressive retear rates. I mean, less than 10% in large and massive tears is really impressive here. So,
Jason, I'm
yeah,
doing it wrong. Those are not my outcomes. I'll
Yeah,
tell you
those
that
are
much.
bad tears too. That's why I read that. Like they're like
these are,
yeah.
yeah, these are big tears. And like, I can tell you from personal experience, just repairing some of these, I, you know, probably I'm in the 40 to 50% retear range. So this is really impressive. Again, I hate to bring this up, but if you are augmenting something, they did look at the acromial interval, and it was interesting that they followed up and it's at 8 millimeters, goes down to 5.6 millimeters. And so I think the big question here is what is actually happening with the graft and the actual tendon. And I'm very, interested again. I would like to see what the Sugaya 3 kind of sub-cohort here is like. Is it a re-tear or is it actually, you know, good tendon that's actually transmitting, the muscle force to the bone? So the one limitation that I had an issue with though in this study was that the operating surgeon was using ultrasound in some of these cases. It wasn't blinded at all. So I think that's somewhat of a limitation. But I mean, impressive re-tear rates. If I got this, I'd start using grass for everything.
Joe, can you like one of the questions that my trainees always ask me the most is when to use a balloon, and you kind of touched on that, and so did Jason. Can you just explain when you use a balloon for any case, really?
Yes. No, no, I mean,
I was like, all right, it's coming.
I think that, you know, I think that when you're classically, there are obviously the on-label reasons that use a balloon, but the off-label reasons that I use a balloon is after I do, I think, a repair at risk or high risk or a high ROHI score, where I do want to offload the repair. I want to offload some of the pull of the deltoid and disruption of that tear area. I want to compress that repair. There's no science to say that that's actually happening or not. And also, I've been doing this long enough now for 10 years with the balloon that the scarring that you get, the crazy scarring between the tendon and the acromion that you see in revisions does not happen. And so I think those are all beneficial. The capsule circumferentially is getting stretched while they're in the sling, which is good, I think, for time 6 week motion because then their capsule's not all sort of collapsed on itself and thickened. So um, again, if cost wasn't an issue, these are options that I think we can consider utilizing more and more.
Oh, that's awesome. Fantastic. So I mean Joe and Jason, y'all both kind of hinted at, but you know, cost being an issue, how often are you using biceps augment, and then how are you actually using biceps augments? Are you keeping it intact distally? Are you centralizing it? Are you using it for true anterior cable reconstruction? You know, given that that's the most cost-effective augment I think that we have, assuming the biceps is intact. Joe, do you want to take
So
it?
yeah, again, when I was early on in my career, I was not a big biceps killer. Even though when I visited Pascal and Gilles, they thought I was kind of crazy American. But I didn't see the point of killing every biceps when the biceps looked okay. And then when people had massive cuff tears, the biceps started to get flat, and I think it was trying to help out. I don't think it was causing disease. I think it was trying to support the disease process. So now pendulum shifts, and there are a variety of ways to do it, right? You can keep the biceps intact on the supraglenoid tubercle. You can take it out of the groove, but not tenodece it distally, just swing it around and tenodece it anteriorly to recreate some of that cable. People have brought it over more posteriorly on the tuberosity as well. So it's very interesting to me that something that caused so much pain and problems before it doesn't now, or as much now. And in the American system, it's a big RVU generator. So I would wonder if that was part of it. Plus, it's another reason to use another product in your case, which generates revenue for somebody else. So I just wonder. I see Dr. McDonald here. He's on. So I wonder. Get his thoughts perhaps.
Yeah, perfect. Peter, what do you think?
Yeah, I mean, I don't have the answer. We're actually going to embark on a study, biceps transposition versus just a repair and, large to massive tears to augment the tear repair. As you know, we did the biceps tenotomy versus tenodesis study way back when, didn't find much difference, but it's interesting to me, same as Joe, that we went through an era where we're always trying to kill the biceps. The French taught us to kill the biceps, and now we're trying to preserve it and use it in our cuff repairs. So it's kind of ironic, but it's nothing new. I mean, as I think at Shoulder 360, somebody talked about the fact that there's articles from 20, 30 years ago showing, you can use the biceps and incorporate it in your rotator cuff repair. I remember Rich Hawkins and Rob Bell talking about it when I was a fellow. So the pendulum swings back and forth in orthopedics, and we'll need some more trials to answer the questions.
That's awesome, Peter. That's awesome. That'd be a really, really, really nice study. Um, Sweet. So, Chris, you want to go on to our the SCR talking about kind of an ultimate augmentation?
Yeah, absolutely. So the next article was superior capsule reconstruction with acellular dermal allograft improves minimum clinical outcomes, but associated with high rates of graft failure and progression of cuff tear. The purpose of the study was to evaluate midterm clinical and radiographic outcomes of arthroscopic SCRs with acellular human dermal allograft. Patients were eligible if they underwent an SCR with dermal allograft for operative irreparable posterior superior cuff tears by a single surgeon. Enrolled patients completed patient-reported outcomes, radiographs, MRIs. At 5-year follow-up, imaging was independently assessed by MSK radiologists. Final analysis include 59 SCRs with minimum 5-year follow-up. They had PROs and radiographs. 81 and 91% of patients exceeded MCID differences for their respective measurements. Radiographs revealed a 63% of patients' final hematocrit grades were 4 at final follow-up with decreased AHI interval compared to preoperative values, and major graft discontinuity was observed in 66% of patients. So this study concluded that arthroscopic SCRs with acellular dermal allograft substantially improved patient-reported outcomes at midterm follow-up with low overall reoperation rate. However, structural deterioration also decreased with AHI increasing. So, Rachel, at this point in your career, when are you doing an SCR? Because I was doing them all the time, and now I haven't done one in 3 years.
Yeah, similar. I also haven't done one in 3 years, and I started doing some alternative techniques for these difficult to repair cuffs, or thinking more about reverse arthroplasty in the right age group with the right expectations from patients. So I don't know. I think my results with SCR mimic this study, and these are good surgeons in this study. So that's even a little bit arrogant of me to say. I think my results are probably worse, and I think that the for me, the big challenge with SCR, especially early on in career, and I'm not that old in my career, is it's a difficult, technically demanding procedure. And if you don't have the right OR time, block setup, different assistants, different scrub techs, it can just be a little bit finicky. Now, I think smaller anchors, all suture anchors, have really helped the technique for SCR and have made it a little bit easier to do, and some graft delivery systems. But that's a long-winded way of saying it's in the algorithm. I just don't know the patient anymore that's an ideal candidate for that. I've gone to, more of a biologic tuberoplasty, cable reconstruction option for these patients if I want to offer them an arthroscopic approach. And many times we're talking about arthroplasty if they want a definitive approach. What is interesting in this paper, and this has been replicated in my patients as well, and I find this with tuberoplasty cable reconstruction, they tend to do okay from a pain control perspective. They're happy. They're happy at 5 years. I don't know if they're happy at 15 years. I certainly don't think it alters the natural history of the cuff and progression to cuff tear arthropathy, and this paper demonstrates that as well. But if you set them up for the appropriate expectations, maybe that's a win. That patient might at age 60 want to get to 65, or at 55 want to get to 60, and then they're okay with maybe a more definitive surgery. And having been a young patient with many operations myself, I'm okay with an operation that gives me a 5-year outcome if I'm told and expecting that. So time will tell with some of the other techniques, whether it's balloon spacer, whether it's permanent spacer with biologic tuberoplasty, or other things coming up. Don't know how long these results will last over time. But long-winded way, stealing the mic of saying I don't really do SCR anymore. I'm sure there's an indication for it. It's just fallen out of favor in my practice.
Those are great points. Jason, is there anything that we do from a soft tissue standpoint, not a reverse, but a soft tissue standpoint, SCR, balloon, tuberosities, and then it actually changes this natural history, or are we just managing sort of symptoms? And then what's your preferred kind of way to manage these symptoms or potentially change the history?
So I don't think we can change the natural history in these irreparable cuff tears. So if you think about the progression of what we've done in the last 20 years, we've, tried this SCR, and we tried the balloon, and we still are waiting for data to come out on these. But, I'm kind of like Rachel, simple guy. I still do simple debridements and tuberoplasty. I don't necessarily do biologic tuberoplasty, but I think that is when you're talking about cost effectiveness, that's a simple operation. Patients do well. That's kind of what we have to use as our baseline to compare against. And I think patients can do really well for a compensated cuff tear with the debridement. So that's kind of my go-to for a compensated cuff tear. I tried SERs for a bit in the mid 2010s, and I ditched it pretty quick. I thought it was a hard operation, and I didn't find that my patients were really getting that much better from it. So, in terms of the study here, it's just kind of similar. You can see improvements, but there's a discordant relationship between the clinical function that patients are getting and the structural integrity of whatever you're doing. So, again, I'm a simple guy. I go simple with the debridement for these irreparable compensated cuff tears.
And so then are you a Pascal below in the camp where this is the biceps that's improving the pain, or what's actually the clinical part that's improving it? Are they able to rehab better? Are you kind of temporarily receding the head?
Yeah, so when I think there's a lot of different ways of doing this operation. At first it started as like a debridement and a chromioplasty, but then people described it as the reverse subacromial decompression, where they did a tuberoplasty, bursectomy and just, I think the concepts here are, you want to make sure that you resect any kind of hypertrophied bursa, make sure that the humeroscapular interface is clear of any of adhesions, make sure the tuberosity is smooth, and then intra-articularly, just making sure that there's nothing else there that's potentially causing pain like synovitis or anything like that. I've become less and less a biceps taker because I think in these big tears, oftentimes it can provide a little bit of stability. So I think all those things put together, that's what I term a debridement, but it's actually a lot of different things. To me, I haven't tried anything that has been substantially better than that.
That's awesome. Joe, you have a long history of innovating in this space with regards to more recently Bloom, but even before that on techniques to sort of augment these very difficult problems from a soft tissue standpoint. Can you maybe just briefly talk about your evolution and where we are today and where you think we're going to go in the future in this area?
Yeah, I mean, I think that I did try smooth and move stuff early on in my career. I didn't really have good results. Actually, a lot of the patients pretty quickly were telling me they were pretty miserable. So, CTA heads were a thing that we used sometimes for these patients and actually did okay. Um, and then, um, as far as IP, concurrently, while they were developing the in-space balloon, developed a dermal allograft, not biologic tuberoplasty, but actually a ravioli that you put in the space, something that's more permanent. That IP hasn't been further developed at this point, but I do think that um, changing the length tension relationship, rebalancing a tear that was previously unbalanced, or teaching it how to be balanced, gets patients back to a less pain level, right? We all have patients that walk in and they had an anecdotal incident. You did an MRI, they have a massive tear. They're like, my pain's like a 1 and my SANE is an 85. You're like, yeah, go do some rehab. I'll see you later. Well, that's basically what we're trying to do with any of these operations to get into that again. It's the ones that come in that are my pain's a 7 and my SANE's a 30. Those are the ones that are going to need an arthroplasty of some sort. So, I think there's a lot of options out there. I think that some of them they're all going to cost some amount of money. Some of them are reimbursed better by insurance carriers or Medicare than others. And you want to minimize the morbidity for potentially the next operation they may need, which most of them do need one.
Oh, that's fantastic. Dr. McDonald, can you weigh in? You've done some beautiful comparative studies. I feel like this is set for one, if I'm not mistaken. I think y'all are already kind of evaluating some of these options or getting ready to. Do you want to weigh in on kind of this idea of kind of trying to recenter it, whether it's an SCR, whether it's a balloon, whether it's a sort of another augmented, not complete repair?
Yeah, I don't do SCRs anymore. I was never a huge fan of them. That, a fiddly operation, as we have alluded to already tonight. And, I think somebody like a shoulder 360. Somebody did a show of hands. How many people do SCRs anymore? And like out of 300 surgeons in the room, nobody raised their hand. So I think it's fallen out of favor. It's that ship has sailed. But I think if it did work, and people, obviously, there are surgeons out there who got quite good at it. There was a steep learning curve, as my junior partner Jarrett Woodmass showed when he was with JP Warner, and that article about the 60% failure rate at a couple of years with 6 different surgeons on it early on in their learning curve. But I think some people got really good at it and were able to restore the force couple of the rotator cuff by doing it somehow, just kind of like a partial repair with some sort of augmentation. So I think that the temporary improvement was due to the restoration of the force couple. And so whether you do it with that or with the biceps or with some sort of cable reconstruction, I think it's kind of all doing the same thing to get to the same endpoint, to restore some of that biomechanics, keep that head down a little bit more so that the patient can more pain-free, have more pain-free elevation. So I think there's a lot of work that needs to be done in this area, and there's a lot of tools in the toolbox, but we just need to kind of have more data as to which is the best choice.
Yeah, that's a fantastic point. Rachel, going back to tuberoplasty, that was one of the other articles that's a part of this. Rafi published a really nice study that shows, 1 year, 2 years, even beyond seems to stand the test of time. So, you mentioned you have that as part of your algorithm. When you incorporate that, and in essence, that's common like some of these tears that Rob had, and Rob and Dr. Burker had, where it tore off the glenoid and then almost acted like the superblasty. So in essence, it's almost like two different studies showing good clinical outcomes over sort of sustained follow-up period. That been your experience, and how do you incorporate that?
Yeah, great question. For me, tuberoplasties really become a good option for where I would have previously considered an SCR. It's not quite the same patient population, but it's nearly, for me, the same patient population. So truly irreparable cuff, intact or repairable subscap, minimal arthritis. And I think that's a critical component here. If they already, if the cat's already out of the bag, even if they're young, I don't think any sort of spacer is going to offer them longevity. But again, if you explain the expectations to them and they're okay with a year or two or three, maybe it's worthwhile to them and whatnot. But those are kind of my indications. And so again, it's that patient who's not yet a candidate for arthroplasty, either due to desire or age. They don't have a ton of arthritis, but they don't have a ton of rotator cuff. And so we're putting some sort of permanent spacer. And I think what we're learning as we continue to do this is if you can get any partial repair of the cuff, do it, particularly the posterior cuff. And usually there's something you can get. That also helps, just to be candid, for billing as well, just in terms of billing for the rotator cuff repair, which is nice. But also if you can get something back there, I think it's nice. Usually at this point in a patient's shoulder journey, they don't have a biceps anymore because they probably had multiple operations or at least one operation using their biceps or with its or tenodesis in the past. But I think taking care of the biceps, if it's still there as a pain generator, is an important part of these operations as well. So yeah, for me, it's my classic SCR patient is kind of my tuberoplasty patient. I think the biggest challenge is the 30 to 40-year-old where they've unfortunately had a very bad cuff injury, which is not a common patient, but we've all seen them, and or the 40 to 45-ish, and you just feel bad not bridging the gap between the glenoid and the humerus. It just doesn't, you don't leave the OR feeling warm and fuzzy with just putting something on the tuberosity. So that may be that patient who still would warrant an SCR in my practice compared to a tuberoplasty.
It's interesting if I can comment. Dr.
Yep.
Matson is, I think, in the audience. Would love to hear his thoughts because I know this weekend he shared some of his thoughts on some of these older and newer procedures. I don't know if he's able to chat, Steve, or not. Is he?
I could put it in the chat. Um,
Okay.
Steve,
I
can we
don't,
get him over to a panelist real quick?
I don't know if you can make him a panelist, but
Yep. That
We'll
would be
work on
fine.
that. Pete,
okay.
so can you summarize all this? Like, not saying you're old, by no means would I ever say that, but you have
I'm
seen it.
old. I'm old.
No, no, never, never. Where are we going? Are we going back to SCRs ever? Or is it going to be tuber plus? Is it going to be balloons? Where in 10 years, what are we doing?
That's a great question. I think that the patches are here to stay. I think that we got to find which is the best one. There's actually, as you know, a lot of options. I think restoring the force couple and getting a patch, maybe with biologics incorporated into the patch to stimulate healing. I kind of hope, as Rachel alluded to, that our biological footprint reconstruction with a partial repair and a tuberoplasty, it kind of is an operation that is something that we migrate towards. But it's anybody's guess where we're going to end up. But we got to figure out some way of getting cuff tissue to heal back, become stronger, and get back to its normal self, and be durable. So there's the challenge for you young guys.
Yeah, great point. Great summary. All right, so we're gonna round this out just briefly on Philippe Valenty's lower trap article, and then round this out, kind of transitioning to sort of salvage operation. So this was a study where Dr. Valente looked at his outcomes of a lower trap, a slightly different technique than the allograft, Achilles allograft that's on here. He uses a semi-T autograft that he fixes to the kind of lower infrastatus and the lateral aspect. tuberosity. He looked at his outcomes in 23 patients with 11-month follow-up, and then 12 patients that had 7.5 years of follow-up, and so somewhat of a longitudinal study. Found predictable improvements ER to about 40 at ER1. Constant improvements. Social bacteria went from 40 to 67, so not not the 80s and 90s that Joe was alluding to, but that did have improvement. Then the VHS score from 5 to 1, and for the most part, when you looked at between 11 months and 7.5 years, it did seem like the improvement stood up or the test of time. He did have one revision for infection. But overall, it seemed like this was a nice study. These are supra-infra and teres tears that he deemed irreparable. And as far as I could tell, didn't do routine sort of partial repairs that I know a lot of people will do to sort of augment the slow trap. And it's a slightly different technique than what's used in the US, but just show this seems to stand the test of time. So, I'd be curious, Jason, is a lower trap resistant transfer part of your algorithm? What do you think your role is? And if it does work, is it because it's a big piece of tissue that's in between the chromium that's almost acting like a spacer, or is there actual dynamic effect that's helping?
I think there's a dynamic effect with the lower trap, and so I think with this study, it's important to understand that the indication is important here. These are really debilitated patients that he's operating on. These aren't just people with some external rotation weakness. These are people with profound lag signs. So, these patients oftentimes can't take their forearm off their belly, or they have a hard time even reaching their mouth because of how much, they have a positive horn blower. So, their active external rotation before surgery was like -20 or net
Yeah.
25. So these are very debilitated patients. And so I think in that setting with that select patient group, this is a good operation. It helps to get them back to neutral external rotation, maybe a little bit past that. And so I think the biggest thing is that in space, if you are trying to reach your mouth or the top of your head, if you don't have external rotation when your arm's abducted, you have a really hard time because your elbow's got to go up so high. And this operation can help to relieve that. So I still use it for this indication, but it's a very select group of patients. I mean, if you look at this is like 23 patients over 11 years and not high volume surgeons. So it's not, you don't see this very often. But for the patient with clear, like combined loss of external rotation and elevation, I'm not sure that this is the right operation. I mean, if they have a profound ER lag and you're trying to you know, address that, that's fine. But I think in terms of someone who has weakness in elevation, this might not be the right surgery.
Yeah, that's a great point. Dr. McDonald, what are your thoughts? This is something I know you've gone through evolutions of different ways of doing this with partial cuff repair, and then of all incorporating this. I know your younger partner Jared Wilmess has been pioneering in this as well. What are your thoughts on using this alone, as Jason mentioned, in the kind of really severe ER lag, loss of external rotation versus some that maybe have a little bit more function? And what do you see the evolution in this respect?
Yeah, I don't do the operation. I send them to Jarrett, but I'm very liberal in sending patients with a severe ER lag over for the LTT transfer. And I think that it works. It's not like it doesn't restore normal function, but certainly improves them to the point to where, they get some external rotation. And I think again, it restores a force couple, especially if your subscap is intact. You get some tissue healing, some biology in there, some collagen in the subchromial space as a spacer. So there's definitely something there. I think if you get good at this operation, it's definitely something that can be used, especially in the ER deficient patients.
Yeah, fantastic. All right, Joe. So then comparing to reverses, reverse is something that has evolved tremendously over the last 20 years. Now it's, being done almost 5.5 times to one reverse various anatomics, and you could argue one of the biggest innovations in orthopedics. So when do you think this is a reasonable, or do you think with a reverse, since we're getting such good outcomes, is that sort of gonna cannibalize this operation or these types of operations, because we can predictably get people back pretty good function when they have deficits, whether it's ER deficits or whether it's the clear patient that Jason talked about?
I mean, I think that if you're somebody doing a high volume of this operation, like a Bastin, like a yourself, then I think that you can say to the patient, I expect that you'll get X% improvement with this range of motion and you'll be happy. And it could potentially be an operation that puts things off 15, 20 years. I think if you're Joe Boot and you've done this a few times and you were not really happy with the outcomes and have stopped doing it, um, I think a person with moderate amount of external rotation deficit, a reverse is much more predictable in my hands, especially with lateralization and tensioning the remaining cuff. And the salvages around the reverse for me, I understand a lot better. So, I did try to adopt some of this stuff early on. I missed the memo about the arthroscopic technique, so I was doing it transacromially as Baston first published. And let me tell you, that is not a good idea. That is one way to destroy someone's shoulder, especially if it gets infected and the acromion doesn't heal. And just don't ask me how I know that. So I can tell you this has a role, but I think it has a role for people who are doing this a lot. Even for Philippe Valenti, I'm sure he does a lot of these in other types of patients, but 23 in 10 years, that's a tough operation to get good at.
Sure, for sure. Yeah, just a point of his, one of I think that the cool things what he does also is he brings around the side, so he really optimizes external rotation. These patients are missing a lot of external rotation pre-op. I think that's why his some of his external rotation numbers are actually quite impressive given the lag time beforehand. So pretty cool stuff. Rachel, when you do a reverse, how are you optimizing external rotation? How are you optimizing the ultimate function? So we know cuff intact reverses tend to get a bit higher ASES scores, constant scores than cuff deficient reverses, especially those that have the true stereoparalysis ER lags. How are you optimizing the function in those cuff deficient, pretty limited function reverses pre-op?
Well, Eric, much to the dismay of the ASCS as a sports doc, I have given up my
Oh,
arthroplasty practice over the last 5 years. So, in those cases, I refer to some of my very well-trained arthroplasty colleagues. So, I'll defer. I mean, obviously, we all know some of the strategies. Joe's mentioned some of them as well already. So, happy to discuss that, but also happy to send that question over to some of our docs who are doing it in real life with their patients.
We still
amazing.
love you.
Jason, or
We,
go. Jason, do
no,
you
I
want
can
to take
say we
that?
still love you, Rachel, just because you don't do arthroplasty.
I mean, where there's a scope, there's hope, my friends. So I try to scope everything I can, and then when I can't, I have given that part of my practice up.
Jason, Joe mentioned optimizing this, so I'm going to bounce it into you. Optimizing it by lateralization, by optimizing your both the remaining cuff, posterior delta. How are you managing these that have cuff deficient? Maybe potentially could be a lower trap in some people's ends, but in the larger percentage, have this really significant need to gain, and at least the studies don't seem to be like we're as good as if the cuff's intact. How are you optimizing the function for these patients?
Yeah, I think I approach it like Joe, where I lateralize more than I usually do. So I'm usually aiming for anywhere from about 4 to 6 for most patients in terms of center rotation lateralization, just to kind of balance out, the risk for stress fracture and stuff like that. But in the patient that comes in with ER lag, I will go out to, 10 of center of rotation lateralization to recruit more of the posterior deltoid. And I think that does help them to at least get rid of that lag and be able to hold their arm out to neutral. For the patient that really has difficulty with, again, as I mentioned before, where they have to lift their elbow up way high and they have a big ER lag in abduction, those are the people where you have that discussion of whether or not you want to add on a tendon transfer as well. In my experience, people hear about that operation and the addition of that portion, they oftentimes decline it, and in my experience, they do okay even with the reverse. But I do talk to them about a combined lower trap transfer sometimes with the reverse for the people that are very debilitated.
Fantastic. Awesome. Well, we have about a minute left. Dr. McDowell, do you want to take us home? What's first off, what's the biggest innovation besides patches that we're going to see in the Rotator space? And then second off, what are you pushing Jared to study next? Y'all have revolutionized with many incredible studies. What's the one that Jared is going to be leading once you put up your hockey cleats?
Well, that's a big ask. Summarize all this, I think that in some respects we're not much further ahead than we were 15 years ago. Pendulum swings back and forth. The only thing that's really advanced more is our knowledge and use of patches and recognizing that they do work to try and restore some healing. But some of the controversies still exist. What's the best technique? What's the best way of restoring the force couple? I think that, our understanding of rotator cuff healing is still deficient. Our understanding of the role of biologics is still deficient. So I think we still have a long way to go and lots of techniques out there, but I think we have to sort it out with more science.
Amazing. Awesome. Well, thank you very much. Chris, anything you want to say before we sign off?
No, this was awesome. And I know everyone enjoyed it so much, and everyone watching online is going to really benefit from this discussion. So thanks everyone for being with us tonight. It was great.
Thanks
Perfect. Thank you all
thanks
very
for
much.
organizing.
Thank
Thank
Thanks,
you.
you.
guys.
Thanks,
It was
guys.
great seeing
Yeah.
everybody. Thank you.
Right.